Good afternoon, ladies and gentlemen. I would like to thank Nestlé Nutrition Institute for this very nice invitation to present this symposium on the association between protein malnutrition, sarcopenia, and dysphagia. My name is Pere Clavé. I'm the Director of Research and Innovation of the Consorcio Sanitari del Maresme at Hospital de Mataró in Catalonia, Spain, and I'm the principal investigator of a research group focused on dysphagia and neurogastroenterology. I'm also the founding president of the European Society for Swallowing Disorders, and this is the list of my disclosures and clinical trials with the industry. This slide shows and summarizes the statement by the European Union Geriatric Medicine Society and the European Society for Swallowing Disorders, considering oropharyngeal dysphagia as a geriatric syndrome, as it is highly prevalent among older people, and it is caused by multiple factors, including frailty and sarcopenia, as you can see in the panel on your left, and it is associated with poor clinical outcomes, including malnutrition and morbid mortality. Right image shows several etiological elements associated to oropharyngeal dysphagia, including impaired olfaction and taste, reduced cortical plasticity and pharyngeal sensory function, skeletal changes, reduction in elasticity and saliva production, and reduction in tongue muscle and poor dental status. These factors interact to cause the two major alterations on swallowing function, including in oropharyngeal dysphagia, such as impaired safety of swallow that is mainly associated to impaired neural factors such as pharyngeal sensory function, a clear reduction on the characteristics of the perception in the pharynx, and prolonged and delayed swallow response, with an increase in the overall duration of the swallow response, and in particular, with a delay and slow reconfiguration and a delay in laryngeal vestibule closure and upper esophageal sphincter opening, leading to aspiration during the swallow response. Therefore, aspiration is mainly linked to neural impairments, starting with impaired pharyngeal sensory function. In contrast, impaired efficacy of swallowing in the early is mainly associated to weak tongue thirst, causing reduced bolus velocity and kinetic energy, causing a weak propulsion and oropharyngeal residue. This slide summarizes the complications of these biomechanical events, and the slide shows the complications in patients with oropharyngeal dysphagia associated to muscular weakness and slow neural response. Complications associated to muscular weakness cause impaired efficacy of swallow, including dehydration, malnutrition, sarcopenia, and frailty syndrome. And the complications associated to slow neural response cause impaired safety of swallow, aspiration pneumonia, leading to high mortality rates. This slide shows the prevalence of these complications and the clinical outcomes of elderly people with oropharyngeal dysphagia at our institution. And as you can see, older patients with oropharyngeal dysphagia present high prevalence of nutritional risk and malnutrition. The type of this malnutrition is a protein caloric malnutrition, high prevalence of sarcopenia, and a more severe reduction in visceral protein and muscular mass in patients in an acute situation, such as are infections or even aspiration pneumonia. An important message is that all of them, 100%, presented intracellular dehydration, and also malnourished patients with oropharyngeal dysphagia needed higher levels of thickened fluids and presented more residue, indicating reduced tongue strength. The study on the right is also performed at our institution. Both studies were published in Clinical Nutrition some years ago, 5 years ago. And the right graph shows that oropharyngeal dysphagia is a prevalent factor for malnutrition in older patients and is associated with a very poor clinical outcome. In this graph, you can see the poor survival of elderly people with malnutrition or oropharyngeal dysphagia, and particularly the high mortality rates associated to patients with both conditions, with a 65% mortality and 1 year follow-up in those patients having oropharyngeal dysphagia and malnutrition. In summary, malnutrition, frailty, and sarcopenia are prevalent conditions in older people with oropharyngeal dysphagia, but they are separate entities. Frailty is a state of diminished physiological reserve where the body is unable to resist minor stressors, leading to adverse events and poor health outcomes, and has specific methods for diagnosis. Protein energy malnutrition can be defined as a status with the result of insufficient energy and protein intake, causing weight loss, wasting of muscle and fat stores, leading to attenuated physical and mental function and poorer clinical outcomes, and has specific methods for diagnosis, such as the MNA and the GLIM criteria. And finally, sarcopenia is an age and disease-related skeletal muscle disorder characterized by loss of lean mass and poor muscle function, also with specific methods for diagnosis. To explore the relations between these three main conditions, this symposium will include the contributions of two experts in this field. First, Dr. Hidetaka Wakabayashi will talk about the topic of dysphagic patients and their association with protein malnutrition and sarcopenia. And second, Dr. Mary Litchford will comment on the role of proteins in preventing protein malnutrition and sarcopenia in dysphagic patients.